Thank you very much. I can call you Jim because we used to call you Jim. In the little unit 41 years ago. My God. Okay. I'm going to talk about pediatric autoimmune hepatitis or better autoimmune liver disease, but in fact not only pediatric but also adult autoimmune liver disease and compare the two. Autoimmune hepatitis type 1, that Diego has described, really affects both adults and children, while autoimmune hepatitis type 2 is mainly a juvenile disease, not only children, but really children, adolescents, and young adults. The presentation is quite different in adults and children, or let's call it juvenile patients. In adults, very often is diagnosed as a chronic disease with mild or moderate severity, while in young people, very often presents acutely and is a very aggressive disease. Now, my adult colleagues, and I would like to know what you think, tell me that more recently, also many adult patients present very acutely. Is that correct? Yes. I see John saying yes. That's right. So it may not be such a huge difference as previously described. In the juvenile form of autoimmune hepatitis, 2/3 of the patients are in fact type 1, and 1/3 is type 2. There are similarities, we are talking about the juvenile form now, there are similarities between type 1 and type 2 autoimmune hepatitis. The majority of patients are girls. 20% of these patients will have associated autoimmune disorders like thyroiditis, maybe diabetes, inflammatory bowel disease, and so on. About 40% have a family history of autoimmune disease. So I always tell my students and my young doctors that doing a good family history is very, very important because it suggests what could be wrong with the patient. And about 80% have high IgG. Now, this is obvious, isn't it? Because we said this, the definition high IgG. However, 20% of these patients do not have high IgG, which doesn't mean they do not have autoimmune hepatitis. So Diego has already mentioned that, for example, in very acute presentation, and particularly in type 2 autoimmune hepatitis, the IgG can be normal. There are differences between type 1 and type 2 AIH. The LKN1 positive patients present at a younger age, and as young as infants, the youngest LKN1 positive autoimmune hepatitis I've seen was 8 months old, so really very, very young. They have very often associated partial IgA deficiency. So 40% of type 2 autoimmune hepatitis have partial IgA deficiency. Don't ask me why, I have no idea, but there must be a reason why they have it. And they present much less frequently with cirrhosis, and more frequently acutely, and even with fulminant hepatic failure, even in very young age. Now, to answer partially what Jim was asking before, in the juvenile autoimmune hepatitis form, particularly autoimmune hepatitis type 1, 50% of the children or adolescents, in fact, do not have autoimmune hepatitis type 1, but they do have an overlap syndrome with sclerosing cholangitis. We described this in the 80s, and we called it autoimmune sclerosing cholangitis, which is now a term which is used by everybody, more or less. What is autoimmune sclerosing cholangitis? It is a disease which presents with a high IgG, high transaminases, autoantibodies, usually anti-nuclear antibody, anti-smooth muscle antibody. You do a liver biopsy and you see exactly what Diego showed you, interface hepatitis with a lot of inflammatory cells, and really no different to what you see in autoimmune hepatitis type 1. And even the pathologist can tell me that. Although here you might see a little damage to the bile duct, but also 20% of autoimmune hepatitis type 1 patients will have some little damage of the bile duct or histology. So how do you make the diagnosis? You can only make the diagnosis if you perform a cholangiogram at presentation, when the patient presents. Now this was an ERCP, a retrograde cholangiography, which we did at the time we were describing the condition. Nowadays, you can use definitely MRCP with nuclear medicine, MRI, resonance, and I can't say it in and this is a very gross abnormality of the bile ducts, which we could pick up when we had MRIs of 1 Tesla, 2 Teslas. And now, with MRIs of 3 Tesla, you actually can see beautiful pictures of bile duct damage, very similar to what you see on ERCP. I stress the fact that you will never make the diagnosis of this condition unless you do an MRCP at presentation, when the patient presents. Now, autoimmune sclerosing cholangitis is different from autoimmune hepatitis because it affects equally males and females. Most importantly, the gamma GT and the alkaline phosphatase, which are biliary enzymes, are normal, very often normal at presentation. So it doesn't allow you to tell whether the disease is more biliary or not. They have very high IgG levels, higher than in autoimmune hepatitis. They're very frequently positive for ANCA, anti-nuclear cytoplasmic antibody. And they are more frequently associated with inflammatory bowel disease than autoimmune hepatitis. About 66% of the autoimmune sclerosing cholangitis patients have inflammatory bowel disease, usually ulcerative colitis, some have Crohn's. But also 20% of the autoimmune hepatitis may have inflammatory bowel disease. What is important is that often, in fact, not so only sometimes, the disease, the inflammatory bowel disease, can be completely asymptomatic, and it's only if you look for it that you make a diagnosis. So it is important to actually look for a possibility of inflammatory bowel disease when you make a diagnosis of autoimmune liver disease in a young patient. Therefore, the diagnostic criteria for autoimmune liver disease, juvenile autoimmune liver disease, is elevated transaminases, which is almost universal, exclusion of other conditions, as Diego mentioned, positive autoantibodies, anti-nuclear antibodies, and the smooth muscle antibody would suggest autoimmune hepatitis type 1 or autoimmune sclerosing cholangitis. You might notice that the titer here is 1 in 20. Not in 1 in 40, as Diego mentioned before. The reason is because children and young adolescents do not have normally autoantibodies at all. So if you do find positive autoantibodies in a young person, this is meaningful, and your laboratory should give you any positivity. If anti-LKM1 is positive, look at the titer more than 1 in 10, equal or more than 1 in 10, or anti-LC1 is positive, then you have autoimmune hepatitis type 2, elevated IgG, a liver biopsy which shows interface hepatitis, and in the juvenile form, very often multilateral collapse because it is a very acute disease, and then a cholangiogram, which should be done at presentation. And if the cholangiogram is normal, the patient has autoimmune hepatitis. If it is abnormal, the patient has autoimmune sclerosing cholangitis. This is what we do normally now in all juvenile autoimmune liver diseases. I strongly believe that adults have autoimmune sclerosing cholangitis, and that is very often missed. I certainly have seen adult patients with this condition. What about treatment? Now, the definition, when you treat somebody, you must define what you want to achieve. So definition of remission is important. And the definition of remission in adult patients is normal transaminase levels, completely normal, and normal IgG levels. We are much more demanding for the juvenile form. What we want in the children and the adolescents is negativization of autoantibodies, or very, very low titer of autoantibodies, but really negativization is better. And then we can make a really definition of remission. Now, autoimmune hepatitis is an easy disease to treat because it responds very well to steroids, plus or minus azathioprine, which is very cheap, obviously, treatment. and it really is very rewarding. It works in all types, the majority of autoimmune hepatitis patients, including liver failure actually, but not so much in fulminant hepatic failure. So if you have a patient who presents with encephalopathy, okay, you may try to treat with steroids, but very often the disease is too advanced and they don't respond, and transplant is the only way. Now, for adult autoimmune hepatitis, the ASLD guidelines suggest to treat with, at the beginning, with 30 milligrams of prednisone plus 1 to 2 milligrams per kilogram of azathioprine per day, or alternatively to use prednisone monotherapy 40 to 60 milligrams per day. And this is the American Association for the Study of the Liver. There is a problem because all of us know that azathioprine can be hepatotoxic, and certainly can be hepatotoxic, particularly in patients with cirrhosis or in patients who are jaundiced and are ill. So the EASL guidelines, so the European guidelines, suggest not to start with azathioprine, and these are adults, okay, but to start with prednisone 60 milligrams per day, and then to add azathioprine only 2 to 3 weeks later, when the disease is partially controlled. What do we do in the juvenile form? The juvenile form is much more aggressive, I said. You need to really hit it hard. So we are much more aggressive in treatment as well. We give 2 milligrams per kilogram per day of prednisolone with a maximum of 60 milligrams per day. Of course, the child weight will be quite variable. But we have a secret not to poison the child or the young adolescent. We decrease the steroids very rapidly, gradually, but very rapidly over 4 to 8 weeks to a minimum of 5 milligrams per day, depending on the size and the age of the patient. So our patients do not look Cushingoid really, or minimally Cushingoid. And we add ursodeoxycholic acid if the diagnosis of autoimmune sclerosing cholangitis is made, and the dose is 15 milligrams per kilogram per day. Now, we never start with azathioprine because of the hepatotoxicity, but we add azathioprine if the liver function tests do not improve as we would like, obviously every week, or if there are very severe side effects for the high dose of steroids. Because it is myelosuppressive azathioprine, we start on a very small dose and we increase it gradually to 2 milligrams per kilogram per day, rarely 2.5 milligrams per kilogram per day. To be able to treat a young person well, you need a lot of effort, because you really need to avoid severe side effects. A girl who is 16-year-old or 14-year-old or even 12-year-old doesn't want to become a monster with steroids. So you really need to go down with the treatment quite quickly. And for this, we do weekly liver function tests, INR and food blood count, and we immediately take action for decreasing the dose of steroids as soon as we get the result the same day. And we aim, in reality, to an 80% decrease of the baseline AST level within 6 weeks, because we have learned out of many hundreds of patients that if you do achieve that, then eventually the child or the adolescent will go into complete remission. 80%, however, of our patients eventually do need azathioprine. So we add it later, but 80% do need azathioprine. In adults, it has been possible to maintain remission on azathioprine monotherapy. In children, it is possible in type 1 autoimmune hepatitis, is much less successful in type 2. I personally wonder, and maybe you can tell me what you think, that there is no reason to have to maintain somebody on a higher dose of azathioprine, which is much more toxic than a very small dose of non-steroids, with some says yes again. So I'm not particularly keen to do this. What we do in the juvenile form, we treat the patients with daily treatment for 3 years, at least 3 years. Then we wait a 4th year, during which the liver function tests have to be normal, IgG normal, and autoantibodies negative or very low titer, checked every 3 months. And if we are in this situation, and we repeat the liver biopsy, And if there is no inflammation at all in the liver biopsy, then we gradually discontinue first azathioprine and then prednisolone. By doing so, we have been able to obtain complete remission without treatment in 20% of autoimmune hepatitis type 1, but in fact in none, or very, very few. We have only one patient with autoimmune hepatitis type 2. So type 2 seems to be requiring treatment forever. We never do it just before or during puberty, because it is the time when we have more relapses. About 40% of the patients relapse. Now, it is difficult to know if it is hormonal changes or if it is because at puberty the girls usually stop taking the medicines and don't tell anybody. But whatever, it is actually we treat the patients in the same way, but the autoimmune sclerosing cholangitis patients do worse than autoimmune hepatitis. This is the long-term follow-up and the middle-term follow-up of our prospective study in 52 patients with autoimmune hepatitis, autoimmune sclerosing cholangitis. And you can see that the need for transplantation was much higher for sclerosing cholangitis than autoimmune hepatitis, because the treatment doesn't really stop the progression of bile duct disease in at least 50% of the patients. And this is the results of the prospective study. We are analyzing the 30-year follow-up now, at the moment. This is not the 30-year follow-up, but the 17-year follow-up. You can see that the transplant rate for autoimmune hepatitis type 1 is 6%, so it's quite low. For autoimmune hepatitis is higher, it's 14%, but this is because some patients presented with a full hepatitis. And the transplant rate for ASC is very high, it's 27%. But what is most shocking, in mind, these are our data, okay? The recurrence of the initial disease post-transplant in our own series is 0% for autoimmune hepatitis. In the literature is reported 20%. But 71% of the sclerosing cholangitis recur after liver transplantation. And some of them require a second transplant and some a third transplant. So the disease is that important. But what we have learned out of experience now of many, many hundreds of patients is that the progression of liver disease and the recurrence post-transplant are very strictly associated with the activity of inflammatory bowel disease. So it is essential to treat the inflammatory bowel disease well, to put it completely under control to stop the liver disease. I've got time. Yeah, okay. I told you the classical treatment. We have alternative treatments for induction of remission, or, sorry, I made it here. For induction or for difficult to treat patients. For induction of remission, in the juvenile form, there has been the use of cyclosporine A for 6 months in autoimmune hepatitis type 1. Then cyclosporine A has been stopped, and then prednisolone and azathioprine was given to all patients. This was an uncontrolled study done by Fernando Alvarez, who is a friend. He had good results, but the benefits are really honestly not clear because we do not see severe side effects from steroid treatment to start with, and cyclosporine, of course, is quite a toxic drug. They were maintaining blood levels of 200, which is really very high. Then there is a study that everybody talks about, which is the budesonide one, 3 milligrams TBS 3 times a day, plus azathioprine, compared to prednisone, 40 milligrams per day, plus azathioprine. This was a controlled study on a large number of patients in Europe, done by Michael Manns, and in children, and I'll show you the data, really there was no difference in response between budesonide and the prednisolone. But not only there was no difference in response, the actual overall response was much worse than the classical treatment. I say a few words about this study because everybody asked me about it. Now, I told you how it was done, but the design of the study was strange because the budesonide was decreased upon response, so looking at the response, while the prednisone was reduced per protocol, so not looking at the response. This was given for 6 months, and then budesonide was given to all patients for another 6 months, and then it was each doctor was treating the patient as they wanted. The definition of response was a little bit biased towards the budesonide because it was normal transaminase levels without steroid side effects. Sorry, I assume you know that budesonide is obviously steroids that have a 90% pass through the liver, and they have much less side effects systemically than the normal prednisone. So this was what they were expecting. In the overall study of 203 patients, they had a 60% remission in the budesonide arm and 39% remission in the prednisone arm, which suggests that budesonide is better. But if you look at the juvenile cohort, there were 46 adolescents and children. You see that at 6 months and 12 months, there is no difference whatsoever in response between the budesonide and prednisone group, but also that the response is much, much worse than the classical treatment. So, which means really that we shouldn't use budesonide in this population, and maybe further studies are necessary. Now, for difficult to treat, and this is my last slide, in fact, for difficult to treat patients, these are patients who are resistant. It's about 10% of the patients who are resistant to the classical treatment or unresponsive to the classical treatment. For these patients, the drug to use is actually mycophenolate mofetil. Unfortunately, they're all retrospective studies. They're not prospective control studies, but the studies show that it is more effective in autoimmune hepatitis than in autoimmune sclerosing cholangitis, and probably is more effective in patients who are intolerant to azathioprine than patients who do not respond to azathioprine. The important thing from my point of view in young people is that it is teratogenic, so one has to be very careful. Now, anecdotal experience has been published with calcineurin inhibitors for rescue, rituximab for rescue, and anti-TNF alpha. Really and truly, they are all mode of treatment which we do not know whether they work or not, and should be used only in specialized centers. Thank you very much.